We're going to turn next to hear a little bit more about antibiotic stewardship efforts, and I'm pleased to introduce our next speaker, Dr. William Frese, who serves as the Overseeing Strategic Medical Director for Blue Cross and Blue Shield of Illinois' Commercial and Retail HMO Quality Improvement Program. Dr. Frese?
Thank you, Catherine. Hello, everybody. I'm appreciative to be able to speak with you today about some key initiatives, Blue Cross Blue Shield nationally, and Healthcare Service Corporation, which for those of you unfamiliar, manages the Blue Cross Blue Shield of Illinois, Texas, New Mexico, Oklahoma, and Montana plans, is doing in terms of some antibiotic stewardship initiatives regarding education, messaging, and some practice-based resources. So specifically what we're going to talk about today, I'm going to briefly introduce some of the Blue Cross Blue Shield national antibiotic prescribing reporting activities we have, and then we're going to move on to showcasing some of the HCSC-specific provider educational practice support resources we've developed. Finally, we're going to wrap up highlighting some HCSC antibiotic prescribing provider feedback pilots. So to help serve as some context, I first wanted to share some key findings published by Blue Cross Blue Shield of Association, which is a national association that Blues companies like HCSC belong to. So back in August of 2017, the association released a 6-year trend report on national antibiotic prescribing among its Blue providers in outpatient settings. So some of the data I'm going to be reviewing with you is a little bit different, but overall consistent with some of the data you've already heard. And the good news was, as you can see from the title on the front cover, national antibiotic prescribing decreased about 9% nationally. But that said, consistent with some CDC data on this subject, there was also a notable national variation by state and metropolitan area in terms of prescribing. In Illinois, for example, although lower nationally, as you can see by the heat map on your screen, we experienced about a 3% increase in our prescribing patterns. Furthermore, there was a large Illinois metropolitan variability, with some areas and pockets within Illinois having prescribing as high as 36%. The report also noticed about 20% of prescribed antibiotics were not indicated, somewhat aligning with what you've already heard in other presenters. Primary care offices served as a large source for these trends, and there were some notable differences between adult and pediatric antibiotic prescribing patterns. So HCSC was already working on some initiatives to better support antibiotic stewardship, but these findings definitely helped further spur our own call to action. So I'm going to be talking about the remainder of what HCSC is doing in terms of various antibiotic stewardship initiatives. And developing these programs, we've tried to take an evidence-based approach with a multimodal approach that leverages multiple behavioral change theories in terms of education, motivational culture change, positive incentives to our provider, and of course, providing some provider performance feedback. Additionally, it's notable to mention that the antibiotic stewardship is really just one component of these broader initiatives that also includes other clinical measures such as immunizations, asthma, diabetes, et cetera, that from a quality improvement perspective broadly work together for a consistent and complementary performance improvement approach. So to begin with, I'm going to show HCSC regularly includes some antibiotic stewardship topics into its Blue Review, our provider newsletter directed to medical group providers, leadership, and administrators. And marketing data has shown that the Blue Review actually has over a 60% regular clinician readership. So it's been an effective tool to consistently communicate to our 5-state provider network. We've done a few articles on the topic. On your screen are some snapshots of the antibiotic stewardship focus series we did back in December, highlighting some HCSC partnerships with the Choosing Wisely campaign, many of you are likely already familiar with, as well as more of an educational type article presenting some key CDC data to our network that also communicated updates on the antibiotic stewardship pilot I'm going to be speaking to you about later on. Continuing along the educational theme, we've also developed a set of best practices for clinical QI topics such as immunizations, asthma, diabetes, cancer screening, and of course, antibiotic stewardship. These best practices act as a mini systematic review, if you will, offering a quick 2 to 3 page, easy to read review of current evidence-based initiatives that our busy providers can consider implementing to help boost practice-based performance. The best practices we're looking at now comes from our more general HEDIS tip sheet that has a focus on HEDIS-related antibiotic stewardship indicators, such as adults with acute bronchitis, children with viral URIs, et cetera. And it helps highlight some tactics such as watchful waiting and other approaches that we've identified there being an opportunity, especially for some of our adult providers who may be less familiar with some of these tactics, to incorporate into practice more consistently. The final educational resource we wanted to share is our quality improvement educational and toolkit database, which includes antibiotic stewardship topics by offering a more concrete blueprint of how to implement antibiotic stewardship programs. So on your screen now is an excerpt of the antibiotic toolkit with offered listings and by various respected stewards, a brief description of the educational components that are covered in the module, the link to access it, some notes of whether it's free or for charge, and then if any MOC credits are potentially offered that providers can help sort through. So by now you might be thinking that all the education is great, but how is HCSC actually helping to translate this into behavioral change amongst its provider network? So this is where some of our incentives, pay for performance, public reporting, and feedback programs come into play. The first being our HMO Quality Improvement Fund, with a program history that goes back to the late 70s, and it continues to have an influence among practice patterns today, even for non-HMO products, since these initiatives are typically implemented practice-wide amongst our network. The Quality Improvement Fund is a set of similar year-over-year consumer and clinical performance measures selected by the company, helps support broader healthcare performance, company and plan credentialing goals, and the performance benchmarks are statistically calculated from internal network and then national quality compass performance data. I have a subsequent slide that goes into this in more detail, but I wanted to first quickly highlight our Blue Star program as well, which is on this slide. And this is a publicly reported performance grading system of our 80-plus Illinois medical groups, for example, within Blue Cross Blue Shield of Illinois, that also has the antibiotic stewardship performance data that feeds into it. And as we know, providers tend to be performance-driven, so this report helps providers cross-compare themselves, their medical groups, and it can also be viewed by patients publicly to help further drive performance in this area. So going back to our Quality Improvement Fund, though, on your screen currently are the 3 antibiotic-related HEDIS indicators that we have included within the fund, as well as their description. And for each of our providers, we'll do a random sample of provider-eligible patients. And as you can see on the screen there, they have 2 to 3 opportunities per indicator to achieve defined benchmarks with associated payment. And we've achieved considerable success with year-over-year increases thanks to this pay for performance program. And so on to our antibiotic stewardship pilot that leveraged claims data towards provider performance feedback. So this was an ecologic study with the goals to identify and provide feedback to HCSC's primary care providers with potentially high and inappropriate antibiotic prescribing behaviors. So how do we build it? The target population was 51,000 of HCSC's PPO and HMO commercial retail primary provider network, and it was then adjusted into specific state plan and provider specialty group cohorts with the assumption that there's a certain bell curve per specialty and perhaps per regional state area when it comes to antibiotic prescribing patterns. So overall, we analyzed 6 months of claim data for overall antibiotic prescribing, specifically for viral diagnoses, using the data code set from, again, those adults with bronchitis and children with URI indicators. which ideally many of you will recognize from a purist approach, there really should be no antibiotic prescribing at all. So again, our recognition flags here were somewhat liberal for this pilot. We also assessed utilization of what I'm going to term non-first-line antibiotics. So not necessarily looking for associations of amoxicillin prescriptions given with viral URIs, but really rather more broad-spectrum antibiotic classes such as quinolones and third-generation cephalosporins that really had no business being part of a viral-associated diagnosis. Again, trying to make this recognition of the extreme outlier providers relatively generous. And from this way, I identified the top 125 prescribing providers within each state out of, again, that baseline population of 51,000. So once we had this list of providers, in addition to the mentioned Blue Review article and some in-person messaging we did around this program at provider roundtable meetings, we then sent letters to these individual providers that basically re-explained the program. It provided the provider's total number of antibiotics prescribed compared to their specialty averages, and also provided some additional data regarding these identified non-first-line antibiotics compared to specialty averages. The letter also gave some Blue Cross Blue Shield contact information for questions and included a 5-question survey about the program, which I'll highlight some high-level results from on the subsequent slides. In addition to the individual provider outreach, we also noticed that we had 4 cluster medical groups, specifically within the state of Illinois, with a disproportionate number of providers, for which we thought it additionally beneficial to communicate to these groups the findings to their medical leadership. So as such, we sent letters to these groups' medical directors with the intent of provider feedback and maybe potential corrective action, for which we included the list of identified providers, the frequency and type of antibiotics prescribed by the provider, and individual encounter data. So to wrap up, what are some highlights that we learned from the pilot? Where do we plan to take it in the future? So for our successes, based upon some of the anecdotal and survey feedback we received from our providers, we felt the program successfully accomplished its goal of increasing potentially outlying prescribers for these behaviors. Somewhat surprisingly, a higher than expected percentage of providers told us that they found the feedback helpful and actually wanted to see some follow-up and some more detailed reporting to help change their behaviors. It also helped foster some new conversations around antibiotic stewardship between Blue Cross Blue Shield and our provider network. As far as opportunities go, we received a consistent feedback from our provider network, needs help and support from us as a payer with patient-direct antibiotic stewardship education, which, while there's patient-oriented approaches offered in the toolkit that providers themselves can implement, this program admittedly focused mainly on the provider network aspect. And so now we're considering what initiatives we can implement in this program's next wave that may assist with these efforts in terms of web-based resources, sending out educational materials with EOBs for suspected services and diagnoses as not needing antibiotics, et cetera. We also learned we needed to better help providers understand the program's measurement approach, generally receiving some comments that suggested that providers did not really understand how the project was conducted, which, although we did briefly explain in the letter, trying to balance out the goal of keeping the letter brief so a busy provider would actually read it, the detail provided was not enough. So we may have to bolster the next wave of letters with a website link or an additional attachment page that explains our approach in more detail. So like any study that uses claims-based data, missing diagnosis data for which an antibiotic may have been indicated may have skewed accurate provider identification. For example, for our non-first-line antibiotics, we saw tetracycline appear commonly. Perhaps this may have been for an acne ICD that just did not appear on the claims. The pilot also didn't really adjust for different prescribing patterns by different outpatient services, such as urgent care facilities versus primary care, where there may be a potential difference. So in addition to some of the considerations I already mentioned, where is the program headed in terms of next steps? For one, the program is going to graduate from a pilot to an ongoing surveillance program, which will be sending out a second wave of tiered feedback letters actually fairly soon, which is going to potentially identify new providers, of course, congratulate previously identified providers who have since rolled off the list, and for repeat providers, send second notifications. From a statistical approach standpoint, we're going to explore increasing the data measure timeframe to a full 12 months, may help eliminate some potential seasonal variation we saw, as well as segmenting out those urgent care facilities I mentioned, which, although, again, given the fairly liberal generousness of our selection criteria, I don't think it's going to have a significant impact. We did, again, receive consistent provider feedback that they felt this to be a cause of them being identified. So at the very least, we need to provide them with this data to address these concerns. And finally, we know we're not the only ones doing this. The CMS antibiotic surveillance program is a great comparative example. And so to better align our data with what providers may be seeing through this program, we're likely going to adopt some of their methodologic approaches in terms of minimal prescribing cutoffs for identified provider populations, which for part-time providers or retiring providers that may not be prescribing a lot may help shift that bell curve a little bit to the right. Although, again, identifying the top 125 out of 51,000 probably will not significantly change what we're seeing, but it will help align this criteria with these other programs to help make it more of an apples-to-apples comparison for our provider network. And I think we're going to hold questions until the end, so with that, I thank you for your time.